Good day, everyone. I hope you had a wonderful week behind you. And of course, I'm very happy to be back once again with all of you. And it's really good to bring you one more topic on embryology. And of course, we do have a very special guest tonight as well. This is Carolina Andrés. Hi, how are you feeling tonight?
Hi, thank you for the introduction. I'm feeling fine, very excited about this webinar.
We are definitely excited as well, because this is something that we didn't talk about yet, okay? We did, of course, had some webinars on embryology this week. However, not really the terminology. So I'm very happy to have you here. And thank you already for presenting on that topic. And also, please just let me remind everyone that, of course, we will start with Carolina's presentation, and afterwards, it will be time for your questions. As always, just type the questions in the chat section, and I'm sure Carolina will be happy to help you out with them. And let me just mention that Carolina Andrés, she is the embryologist at Clinica Tambre, located in beautiful Madrid. So it's really, really great to have one more team member from Clinica Tambre. And well, I guess we can start with the presentation already. Okay?
Perfect. Okay, so great. Thank you for the introduction. And I would like to thank you all for joining us in this webinar, in this session. I'm very happy to be participating. And well, I'm gonna guide you throughout this presentation. And my aim is to clear out any doubts you may have concerning the most important terms that you can come across your fertility journey. So let's start. Here's a brief scheme of what I'm going to follow. We'll start with a simple introduction, cover the main terms that you can listen to during the diagnosis, both the male factor and female factor diagnosis, and end up with the IVF procedure. The terms that are englobed in this part are the most important ones, and I will be concentrating more in this aspect. So once you arrive to your first consultation at a clinic with your gynecologist, you will probably start listening to different terms that may sound or unfamiliar, or you may have heard them, but the definition is not very clear, such as oocyte or blastocyst. So my aim is to clear out any doubts you may have concerning these words, and I will cover them up slowly so all the definitions are very clear. So once you're after your consultation, the first thing the doctor will do is perform or try to do a diagnosis in order to do the best recommendation for treatment. That means that the doctor will probably give you a list of tests that you may have to do. And within those tests, one of them that you would probably both have to do is the karyotype that you will see now. So the karyotype is something that may sound a bit strange at first. So what helps me to clear all the doubts is, like, I think about this image that you might find over here. So this is the result of a test. And what we try to do is analyze the pair of chromosomes that are present in our body. Chromosomes are structures that contain the DNA content, all the information that we need for our cells to function. So in a human being, we will find 23 pairs of chromosomes, but this number can be altered. And not only the number, but also the structure. So with this test, we intend to do this diagnosis because sometimes it can affect the IVF outcomes. So what's most important to form an embryo is that we have the female cell and the male cell. That means the egg and the sperm. That's what we call the gametes. So anytime you hear about the gametes, we're gonna refer to these two important cells. So let's start with the male factor diagnosis. So the main protagonist is the sperm, as you all might know. This is the structure of a simple structure of the sperm. I wanted to point out that it has three important parts: the head, the midpiece, and the tail. So these structures are very important for us because we will analyze them in the spermogram. As you know, the most important diagnostic test that we will perform in order to analyze the male factor is the spermogram. Here we are going to analyze the concentration, the motility, and the aspect of sperm. So in the following slide, you're going to find a brief summary of the different diagnostic results that we can obtain doing this test. So first of all, I would like to point out terms as aspermia, where there is no semen, athospermia, when there's a lack or an absence of sperm cells in the ejaculate, and hypospermia, when we find that the volume of the ejaculate is lower than what we would expect. Concerning the concentration and motility and aspect, we have other terms such as oligospermia, where the concentration of sperm is lower than what is standard as normal, astenospermia, where the motility is lower, and finally, teratospermia, where there are alterations in the structure of sperm. So we can find a combination of these three in the diagnostic result. Also, we have other terms such as necrospermia, where the percentage of dead sperm is very high, and leukocytospermia, where we find cells from the immune system in the ejaculate that may indicate there is some infection. Apart from the spermogram, which is the basic analysis that we do for the male factor diagnosis, the doctor may also ask you to perform a fragmentation test. So this test allows us to detect the presence of breaks in the DNA molecule. So the DNA molecule is the structure that you see over here at the left. It's the molecule that contains all the information, and it has this structure. If we find breaks in one of the strands, that's what we will call the simple-stranded fragmentation. If we see the breaks in the two of the strands, that's what we call the double-stranded fragmentation. And the implications in the IVF results are different. So let's move on to the female factor diagnosis. Here, the main character is the egg, as most of you have already heard. But there are other terms to refer to the cell. For example, the ovum, or more scientifically, the oocytes. That's how we call them at the laboratory. So the structure of the cell, or of the oocyte, is formed by also three important parts. The pellucidal zone, which is the outer layer, the cytoplasm or ooplasm, which is this big part that you can see here, and then the polar body. I will explain to you a bit more about concerning the classification of oocytes in the following slides. So, concerning the female diagnosis, the most important thing to do is analyze the ovarian reserve. It is important for doctors to know how many oocytes we have left in our body in order to see how we are going to respond to treatment and also to give a diagnosis. So there are two important tests to analyze the functional potential of the ovary, which is the antral follicular count, which will, with the ultrasound, the doctor is able to count the oocyte, the follicles, the antral follicles in our ovary, and then the anti-Mullerian test, that is a test that's done in the blood, and it analyzes this hormone that is liberated by the follicles that you will see in the ultrasound. So they are both related with the ovarian reserve, and they are also directly related with how the body is going to respond to the hormones in an IVF treatment. So once the doctor has all the information that it needs to perform a diagnosis, a correct diagnosis for the couple, he or she will indicate what's the best treatment that suits for your specific case. So there are many different treatments that can be done, but I'm going to focus especially in the IVF procedure. This treatment englobes a lot of terms, since we are going to call you each day after the egg retrieval. That's the reason why I'm going to focus more on the terms that are going to appear after the egg retrieval. Before, it's all concerning the stimulation and medical terms. So let's start with the day of the egg retrieval. This day, the doctor will do the punction, or the ovarian punction, and extract all the oocytes present in it. And us in the laboratory, we will receive the oocyte and classify them. This classification is very, very important because we can only perform the microinjection in a certain number of, a certain aspect of oocytes. So we can classify oocytes in two different groups, the immature group stage and the mature stages. So for the ICSI treatment, we're only gonna use the oocytes that are within the mature stage. That means metaphase, the metaphase 2 oocyte, which I already described its structure, as you can see over here. But we will also find other oocytes that have different morphological aspects that tell us that they are immature and therefore that we cannot use for the treatment. Therefore, they will be discarded and cannot be used. So once we have the oocytes classified, we will perform the microinjection. That means that we're going to introduce one sperm that we select into one of the oocytes. This process is repeated as many oocytes as the patient would have, and later on they will be introduced in our incubators. There are many kinds of incubators that you can find. Probably you've already heard about it. One of the most known lately is the time-lapse incubators, which have incorporated a camera in order to check the embryos at all times. They will be recording their development throughout 24 hours. So for us at our clinic, what we do is culture these embryos in our incubators until day 5. That means that we culture embryos until the blastocyst stage. This is very important because this technique allows us to perform a better selection of the embryos, since only more or less about 50% of the embryos that are fertilized correctly are going to arrive to this stage. And that means that their potential of implantation is higher if they are of good quality. But that I will focus on in the following slides. So after the microinjection is performed, we have to wait one day, and the next day, that morning, we will check fertilization. It is very, very important for us to check fertilization because it's a way for us to know which of these oocytes has potential to form or to develop and start dividing into embryos. So in this day 1, we intend to check some important structures that appear in the oocyte, and these are the pronuclei. These structures that you see over here, it is important that we see 2 of them, one that comes from the mother and the other one that comes from the father. We can also see either non-fertilized oocytes where we don't see any of the structure. That means that they're not fertilized, and therefore we will not count them for the culture. They will be discarded. And then we have incorrect fertilization, oocytes which are not fertilized correctly, like the ones you see over here. We can see oocytes with 1 pronuclei, or maybe with more than 2, like 3, 4, etc. So these oocytes in a normal case scenario would also be discarded. However, sometimes oocytes with 1 pronuclei which arrive to blastocyst stage will be considered for the genetic analysis. So only in those cases, because sometimes in like 20% of the cases, they will be euploid. But if we're not doing the genetic analysis, we will discard them automatically. After the first day, embryos, we expect them to start developing and start dividing. So on day 2, the oocyte that was fertilized, we expect it to see 4 cells. The divisions must be complete and form like complete cells. In day 3, we would expect embryos to be at 8 cells, 10 cells, or maybe more, where we could consider them the morula stage. And later on, they would start the process of compactation. As you can see in this image, they would form the compacted more or less stage in day 4. In contrast with the previous days, these days does not provide as much information. That's why probably in most of the clinics, or at least what we do at our clinic, we do not call our patients, since it does not provide as much information concerning its quality. So it's better to wait until day 5 to see if they have been able to form the blastocysts or see how they are developing. So concerning the quality during the first days, we, at the cleavage stage grading, what we do is check the number of cells. They must have a correct number of cells for the day they are. It's very important for us to know, because if they're going very quick or very slow, that's also an indicator for us about their quality. But also we will take up account the percentage of fragmentation in the embryo. So as I said, cells must divide completely. If during a cellular division there is a kind of debris that's being that's been wasted at the interperivitellinar space, that means the space around the cells, that's a poor prognosis factor. So we would grade fragmentation from 1 to 4, 1 being the lowest and 4 being the highest. So we would consider embryos of good quality, embryos which are grade 1, grade 2. However, grade 3 and grade 4 are embryos with of intermediate quality, which prognosis is lower. So finally, we arrived to the expected day. We arrived to day 5, where embryos, we expect them to form the blastocysts. So you have probably heard a lot about the blastocysts. The image you see over here is an image of an embryo at blastocyst stage. It's formed by 2 important parts: the inner mast cell, which leads to the formation of structures of the fetus, and then the trophectoderm, which forms the layers that the outer layers that are gonna form the placenta. So we also have a specific grading system for blastocysts. In our clinic, we use a system that's called the Gardner grading system that I'm gonna explain to you now in simple ways. So first of all, we give a number to the blastocysts that goes from 1 to 6. This number refers to the expansion of the blastocysts. So blastocysts that are starting to expand, that are starting to form this space over here, we would call them blastocyst 1. And as soon as they start developing and expanding more, we will give them blastocyst 2 and blastocyst 3. Then we would have blastocysts with the number 4 and 5, which are blastocysts which are starting to hatch. That means that the zona pellucida that we saw before, it's going to be so thin that it's going to start breaking and the embryo is going to start going out. That's good. Embryos normally naturally do this process, so it's a way for us to tell us that the embryo is going out from the zona pellucida. So 4, it would be like more initial, and 5 that it's already gone out. And finally, blastocyst 6 would be if we intentionally do a hole, that for some certain cases that we are going to see now, we have to do it. We do the hole and the blastocyst starts going out. Then, concerning the quality of the structures, both structures, both the inner mast cell and the trophectoderm, are gonna have a letter that goes from A to D. A and B are considered of good quality. The only difference in between both of the letters, both for both parts, is the morphological aspect. It allows us to differentiate in between, for example, inner mast cell, which is more compact, more small, compared to another one that's a bit bigger. But concerning the quality, is the same. Now we will speak differently concerning letters C and D. When we see a letter C, is that there we do not see one of the structures. So if we have the C for the inner mast cell, that means that we cannot see the inner mast cell, as we can see overlay in this image here. Later on, the letter D stands for a quality that when the cells are starting to be damaged, are starting to deteriorate. So that's a way to tell us that the structures are not good. Finally, with these good quality embryos, there are different destinations, there are different things that we can do. The first option would be to transfer the embryo. That means place the embryo into the uterus with a catheter that you can see over here. Another option would be to vitrify embryos. That's something also completely normal. In some cases, patients maybe cannot arrive to the transfer date, or maybe the endometrium is not prepared, or other reasons. We have to vitrify embryos, and that is completely normal. The embryos, it's a very rapid freezing where embryos are maintained at -96 degrees in our nitrogen liquid, and when they are needed, we will thaw them and use them for the transfer, for example. And finally, one of the last uses would be to analyze the embryos genetically, so perform the pre-implantation genetic testing, which I'm going to cover during the following slides. So, the PGT procedure is a procedure that's also done regularly at the laboratory, and you can see it over here. So embryos are placed on a dish, and we're going to observe them under the microscope. Our intention is to obtain parts like 3 to 5 cells to analyze them genetically, and then send them to the genetic laboratory for the analysis. So there are different kinds of pre-implantation genetic testing. The most common one would be the aneuploidy testing. That means that we're going to detect loss or gain of genetic content. But we also have the PGT for structural anomalies, where we want to analyze if there is an alteration in the structure of chromosomes. And finally, we would also do monosomy testing for the PGT, which means that we have the capacity to analyze or to detect the transmission of certain diseases from the parents. For instance, Huntington disease. So I'm going to cover the results that you may find in the PGTA, the PGT for aneuploidies, because that also brings a bit of, the terms they use is a bit strange. So let's see the results you may find. So first of all, the normal result would be the euploid embryo. That means that our embryo is correct genetically speaking. It has the 23 chromosomes and with no problem. Then we can also receive aneuploid embryos. That means that there's a gain or loss of genetic content, which affects 1 or 2 pairs of the chromosomes, the structures that we already mentioned in the karyotype. And finally, we can also check mosaicism. That means that within the same embryo, we can see cells that are euploid and cells which are aneuploid in different percentages. And depending on the percentages, the genetic laboratory would give us some indications concerning the transfer of these embryos. So I think I've covered most of the important aspects. Thank you for listening, and I'm open to any questions you might have.
Thank you so much for explaining all those details, because again, I think it's very useful to everyone to be able to see what we're talking about. Yeah, so sometimes those terms are not that easy. So thank you so much. You've explained it brilliantly. So thank you so much for that. And yes, now it is time for your questions. So I can only encourage you to use this time. And of course, Karina is here for you. So go ahead and type those in. Okay. Natalie has added one question already. So let's get to the questions. Okay. Let's start with the questions. The first one is here. So what are your thoughts on refreezing already thawed embryos?
Okay, so this question is very interesting. It's something that we do at the laboratory. In some cases, for instance, we have some embryos frozen, which we have not analyzed them genetically, and at some point we want to analyze them. So we would do the thawing procedure and then the freezing, and we can do it without any problem. It's true that it wouldn't be our first choice. It would be better to do the genetic analysis before, but we still can do it without any problem. I hope I've answered correctly.
All right, excellent. Thank you so much indeed for that. And Natalie has one more question for you, actually.
Yes.
Let's have a look at that. And okay, so again, interesting question. Is it true embryos stop growing after day 3 because of sperm factor?
Well, it's true that when we see that embryos stop at more at day 4, day 5, we would say that it's more a male factor. However, it is important to analyze each case specifically. As I said, each case is different, and it's important to analyze all aspects. But talking in biological terms, it's normally associated with a male factor. But as I say, we must be careful and analyze all the case.
Thank you so much for the clarification to this one. And someone is typing, so we just need to wait a bit to see more questions. And of course, okay, Natalie has also added, thank you
You're
for
welcome.
Sure, of course, that's why we are here. And again, let's give it a second. Let's wait for some more questions. I do see someone is typing, so of course we should have it in a minute. And let's wait then to make sure that we can answer all of your questions. Okay, so go ahead and do it. Okay, here it is. Margie has added what grade embryos should be transferred first.
So our indication would be to transfer embryos which are AA, which is like the top quality, and then we would consider then we will transfer embryos which are, for example, BA. We at our clinic we prioritize the quality of the trophectoderm, but as I say, each clinic has their own protocol. But for us, transferring the first one would be the plasticity AA.
Thank you for the question, and of course for your help, Carolina, to this one as well. And let's have a look, okay? And let's have a look if we have another question. It is here. Okay. Natalie is having very interesting questions, that's for sure. This is probably something that you hear a lot as well. So can mosaic embryos correct themselves, and when do you transfer such embryos?
Yes, so this is a very interesting question. Mosaicism is something that we are starting to see because of the advances in the PGT technology. Mosaicism, concerning regarding the question if they can correct themselves, it is important to know that when we analyze the PGT, we do the analysis of cells from the trophectoderm. So we don't know if the aneuploidies are going to englobe all the embryo or just a part of the trophectoderm. So it's a question that's very difficult to answer, but as I say, mosaic embryos can be transferred. It's something that the genetic laboratory will give you the indications for the transfer of these kind of embryos and inform you about all the risks. So these embryos would be transferred only after all the ploid embryos are being transferred.
Perfect sense, of course. Yeah, definitely interesting topic when it comes to mosaic embryos. Thank you for bringing this, Natalie, to us in such case, of course. Okay, and Margie has a follow-up, okay, in regards to her previous question. So how do you prioritize, sorry, and 5AA, and what will be the next chosen?
Okay, so concerning the transfer, maybe I wasn't very clear. So we would choose the embryo that's more expanded. and also like we have to take into account different factors. For us, it's more important to check the quality. So embryos with the best quality, that means with letters A and B, would be transferred. At our clinic, for example, we do not transfer embryos which contain letters C or D in any of its parts. So first of all, embryos AA would be transferred. For example, as you say, a blastocyst 5AA. And later we would transfer, for example, a BA. For us, we would prioritize that the quality of the trophectoderm is better than the inner mast cell. So that's we would choose BA, and then maybe we would choose a blastocyst which has an A in the inner mast cell and a B in trophectoderm, and finally a blastocyst BB. As I say, the most important thing that you must know from this is that blastocysts with these letters are blastocysts of very good quality. Both letter A and B are very good quality blastocysts.
Thank you so much once again, of course, for explaining that. I do think that it's been very helpful. And okay, one more question from Natalie we have. So do you often do transfers with mosaic embryos at your clinic?
So we've transferred mosaic embryos. We haven't had much cases because normally, as I say, we prioritize euploid embryos which have higher implantation rate. So I cannot say like numbers since I don't know, but we have transferred mosaic embryos that have developed into a healthy pregnancy.
Thank you for the clarification again. And let's have a look. Okay, Margie has added one more comment just to clarify. So that would be 5BA, 5AB, and then 5BB. Yes?
Yes, at least at our clinic we would choose them like that.
Okay, that's perfect. Thank you so much, also Margie, for of course bringing that here as well. And it looks like that might have been our final question. But of course, I definitely want to make sure that you have asked all the questions. So go ahead and type this in if you have something that you would like to ask. But of course, remember that you can always get in touch with Carolina and her team at Tambre, Clinica Tambre, and I'm sure they will be happy to help you out. And I will also put the link here. If anyone would like to get in touch, this is the way to do it as well. And also, before we finish, is there anything else you would like to add before I let you go?
No, I just want to thank you all, and I hope that this webinar has been helpful and has clarified any doubts that you may have.
All right. Again, thank you so much. And we will be finishing for tonight. So thank you, everyone, for spending another evening, Friday evening with us. And I do believe it's been very useful for you. And well, remember, it has been recorded. So of course, you will have a chance to watch this again. And as you can see, there are some thank yous coming up right here for you from our patients. So thank you so much for your questions as well, of course. And yes, one more thank you is right here as well. All right, excellent. And of course, as I've mentioned, we will be finishing, but of course, you will be able to have a look at it. The video will be available tomorrow on our website, My IVF Answers, and our YouTube channel. So go ahead, check it out. So there are over 300 webinars available, so there are plenty of topics to choose from. And once more, Carolina, it's been a pleasure to have you here. Thank you for explaining all those terms. Now, definitely, it's much more clear to everyone. And of course, it's been a pleasure to have you here. Thank you so much. Take care, everyone, and have a lovely, wonderful weekend. And I do hope to see you back here on Monday, 8 p.m. UK time. We will be back. Thank you so much. Bye.
Thank you. Bye. Good night.